So now what I would like to introduce again here is Mr. Joe Marshall, who is our Business Support Director for the Defense Health Agency. And what he's going to talk to you about is a couple of the product lines, okay, the lines of effort that we are doing in the Business Support Directorate and driving towards enterprise solutions and driving towards what we call joint first solutions. So, Joe, go ahead.
Okay, good afternoon. So I know that you guys all live and breathe DoD medical business systems, and I want to reassure you, first of all, that the goal of the MHS is care, and care is always in the foreground, okay? But business has to work, okay? It used to be an excuse that care was in the foreground and business could just be broken in the background. We are now moving into an era where we can no longer afford that. And if we choose to continue to sign up to that, we're going to have to make other decisions that are going to be unpleasant. Okay, and part of those decisions are, frankly, DoD's drive into financial audits, which require that these business systems be integrated, be holistic, and operate in a good and accountable way, is how I'll describe that. All right, next slide, please. Okay, so the standard disclosures. Next slide, please. This is just what we'll just talk about. Next one, please, Dave. Okay, so how many of you use banks? Maybe I should ask how many of you don't use banks, because there's always a holdout in the crowd, right? All right, if you use banks, you know all you need to know about shared services, okay? You get what you need, when you need it, in the amount that you need it, okay? And you feel like you get satisfactory service, or you take your business somewhere else, okay? And so the vision here on shared services is that, all right, there's lots of things that we do. We do these things commonly, and if we integrate how we do them across the system, we can do them with greater fidelity and better cost effectiveness. We've just got to get ourselves organized to that end, okay? And I know that you guys have been living and breathing this your whole military career, or if you're now a civilian when you were in uniform, or if you're a civilian and you moved around in the system, you know exactly what I'm talking about. You've worked in places where business seemed to just flow. If you needed a particular service, if you needed a contract, if you had a facility issue, things got done, and done well, and with confidence, okay? And then you've worked other places where it was problematic, where everything seemed to be very hands-on, and if you weren't very hands-on, it didn't get taken care of. Okay, so the vision here behind shared services is that we can take that first experience where things work well, and we can take that earlier little discussion around banks, and we can figure out how to do this, okay? The challenging piece is the cultural piece, okay? Because we like our stuff. Army, Navy, Air Force, or others, we like our stuff being in our lane. We like having absolutely positive control. So the arc of history bends toward justice. Okay, I would suggest that the arc of the DHA bends toward better shared services. It is going to be a longer discussion about how do we get all the equities on the table. And before we can do that, we have to build trust in the conversation. We have to understand what are the goods that we all get out of these things, and what are the risks that we all perceive. And then how do we move forward from there to get the more effective processes for all of us that we can all afford. All right, so here's the list of shared services, and I'm sure you've seen this list sometime earlier today, so I won't belabor this. This was the first 10. Okay, I actually have a copy of the 1947 report that looked at the service medical activities. You know, it's typed and has holes punched in it and is signed and is yellowed and has all the things from a vintage of that time. But it's interesting in that some of the very things that we have been talking about in shared services over the last 2 years are very prominent in that report, okay? So again, our forefathers all saw this and saw it clearly, and now you and I are tasked with delivering on some of this vision. So there are several of these things on this shopping list that actually belong in my area. Facility planning is one, and I think there's lots of commonality that leaps out to all of you in the facility area. Logistics, which has had, frankly, probably a decade or longer of various directives coming out of OSD saying, let's get better aligned on logistics and how can we do these things better. So we've been able to leverage that, and again, we're seeing some really nice success in facilities and in medical logistics. It's not all done. It's never all done, Okay, but we have some nice things to our credit. Today, I thought as a little excursion, we'd look at budget and resource management, because this is an area where we're still growing, but I think it will speak to you in several ways. Because again, we'd like to figure out ways, while still respecting the fact that people like having their money and using their money in an effective way, how can we leverage the processes to get to a better place? Okay, and so we'll just talk about a handful of initiatives as examples there. All right, next chart, please, Dave. Okay, so you start where you start. We have what we have. Okay, we didn't get here by accident. We got here through very purposeful decision by those who came before us. Okay, and those things work in some way, perfectly designed to produce the results they produce. Okay, however, when we look at this shared service thing, then how can we get to a better place? Now, my boss talks about the county option. How what you do is you build a highway, but then somehow there's always some detour that somebody likes to take, okay? That's the one in the audience who's, putting the money under the mattress, okay? So, so again, what we have to have, what we must have in this is the cultural buy-in and commitment, okay? And unfortunately, that's not up here on the podium. We're all in, okay? That's you, okay? So part of the discussion today is to further your understanding of what we're working on, and to get your support and your buy-in about the places we have to go. And so some of that cross-cutting means we've got to build the trust. We got to have some vulnerabilities exposed here. We got to be willing to say, we're not really very good in my particular culture at X or Y, and that's why we do it this way, is to minimize our risk, because that's the way it has to be, because that's not a strength in our culture. And then figuring out how do we leverage that more effectively through the efforts of others. So the long-term view would be far more integrated on the business side, far more standardized, and producing the results that we need to produce, so that again, care is in the foreground and effective, business in the background, but effective, and doing that in a cost-effective way. Okay, and so part of this discussion happens under the cloud shadow, sorry Dave, of the EHR, okay? Because the EHR, as many of you know, brings tremendous new capability, right? So for a long time, we've thought of patient-level accounting as being a bridge too far, okay? Well, now we're about to buy something that frankly is a register of event by event at the patient level, okay? So it opens new doors, it opens new possibilities. And I know from talking with many of you that many of you see those possibilities, and you have lots of questions about, hey, can we just eliminate this as a legacy system or process and skip to a better future? Okay, so we're having those same discussions inside the DHA because we see those opportunities as well. And we're anxious to leverage your enthusiasm and the opportunities that you see into how we build this into a better future. Next chart. Okay, so here's a place to start. Common cost accounting. So if you've worked in a tri-service environment or in the hospital of another service, you know that frankly, we don't even define the terms the same way. Supply means something different in every culture. Again, this isn't by accident. This is because frankly, we all bought different legacy systems. We all went our different way, and within the various cultures, they have over time been defined in a different way, been captured in a different way, because those were good principles around which to organize, and they were processes that made sense, okay? But now, being in a medical enterprise where we can't talk about things that should be routine and common in a common way makes no sense, okay? So now we have an effort underway, big push by Dr. Woodson himself to say, let's go off and figure out how we can define all the things that we can, okay? This is not going to be a perfect solution. Okay, STARS, which the Navy uses as its accounting system, dates back to the 1960s, 1970s, okay? It does not have the capability that GFIBS, the Army accounting system, has. So we're not going to be able to set all the definitions exactly as we want, but we should have commonality wherever we can. And out of that, we expect to get, some amount of goodness. Okay, next chart, please. So, over time, so this kind of repeats what I just said. So over time, we got where we are. So now we see the opportunity to say, okay, let's enter into an environment, let's commonly define everything that we can, let's agree that we're going to organize and stay organized that way over time, and stay on that path as we continue to improve our financial processes and financial systems, frankly, due to other demands, specifically audit. Okay, so again, this improves our data and it improves our reporting and improves our systems, and it's the right thing to do. It's not a panacea, but it's a place to start. Next chart. Okay, so this gives you a little bit more detail on this cost accounting structure. I don't want to belabor this point. If you're in the finance realm, you clearly understand the things that I'm talking about. And if you've had occasion to dabble in the finance realm, you know what I'm talking about. Clinically, it's probably been transparent to you. But again, getting commonality, setting standards, and enforcing those standards is no mean task, but that's what we're about. Next chart. Okay, so our timeline is to get this out the door by, frankly, September of next year. Okay, and so the impact on the services is going to be some of the things I talked about at the beginning. We're going to have some trust. We're going to have some handshakes. We're going to have some acceptance about what do these terms mean, and accepting a broader definition of what these terms mean. So no mean achievement, and it is well underway. Next chart, please. Okay. So there's a law that says when we provide clinical services, if you have other health insurance, we are obligated to collect from your insurance company for those services. Congress passed this law because, frankly, they want to control and to drive down the cost to DoD of providing clinical services. It's not a suggestion, it's not a good idea, it's not another administrative program, it's the law, okay? And it isn't that, oh, yeah, it's easier at the big activities because they have more staff and more infrastructure and they can really drive this forward, and so we'll emphasize those activities. We'll let the little activities go because it's just a lot harder there. No, the law says all, okay? So frankly, for 10, 15 years, we've had a system called TPOCS, okay, which some of you may know, which has been instrumental, and it's been a terrific thing because it was the same system for Army, Navy, Air Force, and gave us a way forward to better do this task in a common way. Okay, so when we got to the end of TPOC's life, frankly, we went through a process where, well, what are we going to do? It looked like it was going to be an expensive solution to come up with a new corporate solution. So we initially looked at each of the services going their own way, okay? After a little bit of time doing that, the services came back and said, hey, we've looked at this, and frankly, the three of us have agreed on a way ahead, okay? And this is this system that we call AMSUS, okay? So great news. We have the opportunity here to establish a far more comprehensive, a far more effective system for doing patient billing and collecting. Part of the challenge in this program, if you're familiar with it, is denial billing. So you're an insurance company and I bill you, you'll deny the claim, and you'll do that 8 or 9 times. You'll do that because you're an insurance company. You'll do that because you're living on the float, because you don't want to pay me and you want to draw it out as long as possible. Some of these collections can take 18 months, 2 years, or longer to effect, all right? So when you begin to think about, so how do the MTFs do that? Well, they've all built some amount of infrastructure, some amount of contract support, okay? And our Air Force colleagues have been better about kind of getting this effort into the contract realm than others. So we have some very good processes here. So moving this into a common solution that is far more contract-based and frankly in a system that provides lots of the inputs that are needed to make this process flow, to make it effective, this is goodness for us all. So so next chart. Okay, so the abacus is on a path to implement, frankly, next year. We would hope by the end of with the implementation of ICD-10 in 1 October, okay, As with every program, there are issues and challenges around it, so we are still working it. It's not all done yet, but we're very optimistic that we're on the right path to a good solution. Okay, so now, implementing GFibs up at Walter Reed. All right, so when the NCR stood up, interesting dilemma. Navy STARS system, Army at Fort Belvoir with GFibs. What's a mother to do? Okay? You now have both of these things in one house. You're trying to think of them as one house, as one is an extension of the other, however you choose to think of that. And you know that audit is coming, and you frankly would like to have a single system for lots of reasons. More effective use of resources, more integrated use of resources, a better way to look across the enterprise and see what you're buying and why. All right? So, GFibs, not a perfect system, as our Army colleagues will readily admit. And if you know how to use the University of Google, you can Google the GAO reports yourself to see what the challenges are in that system. But no doubt, hands down, far better than the STARS system Navy was using up at the old Bethesda. So we're moving this into 1 October. This stood up in the NCR as their financial system. Okay, there's a downside is that DIMLS is not linked to it. That's a process that still has to play out and is being heavily worked. So along about April, the logistics system will get linked back into finances. Those of you who know what I'm talking about know that this is a difficult time for our colleagues up at Bethesda and down at Belvoir. But we're actively working this, and make no mistake about it, this is goodness. Okay? And it also, frankly, sets up the template for others who may want to look at this as a process for going forward, because we have a variety of financial systems at work across the MHS. And again, as we are tasked to do more and more, particularly around financial audits, having things more integrated and more streamlined would be in everybody's interest. So not easy, but an opportunity. And there's some terrific things that can be done in there, particularly as we work through the challenges. Okay, I think that's my last chart. Okay, so 3 little vignettes, if you will, to demonstrate to you the commitment and the engagement we have on these business systems, and there's a lot more to follow. Any questions? Sir.
I have a question. I'm Mike Eppinger. I'm a recently retired Air Force surgeon, newly hired VA surgeon working in San Antonio. From the DoD perspective, you know, you showed a couple of times now, we saw the big bubble is purchase care. And that's, you know, if you want to save a lot of money, that's obviously the part where the biggest amount of money is being spent. So in terms of that purchase care, one way to do it, like you pointed out, is recapture. Find out which patients you can get back into our system. But even so, there's no way that we have enough DoD resources to take care of all of that. So the other part of it is, how do you impact the amount of money that we're spending on purchase care? From what I've seen, most of the assumptions like, well, that we just got to pay what they charge. That part of the problem, not just with our healthcare systems, but with the United States healthcare system, is that pay for procedures. We don't pay for outcomes, we don't pay for healthcare, we pay for procedures. And frankly, a lot of those procedures are totally inappropriate and they're very expensive. I'm a cardiac surgeon. The majority of coronary interventions that are done in this country are not indicated, but they get paid for. And part of our problem on the DoD side of things is that we don't even know what we're paying for until we've already paid for it. We don't know where our patients are on any given day. We don't know which of our beneficiaries are being taken care of in another hospital. Kaiser doesn't do it that way. Every single morning they meet and they know where every single one of their beneficiaries are, and they're on the phone calling up that hospital like, hey, get that guy over into our system and we'll decide how to best take care of him. But we have no infrastructure on the DoD side of things to even look and see where our beneficiaries are going and what we're paying for. We just have a system to try and pay the bill after the fact, and it's expensive to do it that way. So how do we, is there some goal that DHA is going to look at to really attack the big ball, which is all the purchase care?
Yeah, so I would agree with you, okay, first and foremost. I believe that the path that we're on now with the stand-up of the DHA sets the template for how we can do this more effectively. Again, I think it takes time to work this out, okay? But I will tell you, to your point, if some of you I know worked with Guy Clifton when he was working in TMA, trying to figure out about the next generation of contracts. So some of the work that Guy Clifton and I did was on this very point. So if we looked at purchase care spending in certain regions, you could see certain trends that didn't match up with other regions and other trends, okay? And so one of the things that Guy and I talked about was, why don't we get Army, Navy, Air Force together and decide what the standard of care ought to be, okay? And then frankly, we can figure out how to put that into the managed care process, okay? And Guy was very willing to have that conversation and very willing to explore that path, okay? Having said that, that's a mouthful of contract language, okay? And it's kind of a way that we haven't been doing business, okay? And so I think now with the stand-up of the DHA, there are opportunities to pursue that kind of thinking with much more vigor, okay? And so I'll stop there in case the boss wants to talk.
Yeah, I think we're also using the term as, pay for value, which is kind of, the trend right now. And so as we're going to affect that through our next two sets of TRICARE contracts. And so we're thinking along the same lines you are, because that's what the nation's thinking, when we talk to the Kaisers, when we talk to the Intermountains, when we talk to the Uniteds, when we talk to the different large networks out there. And so what you're going to see is you've got two sets of contracts coming up. You got 2017, all right, and that draft proposal's out right now, okay? And that's what we're going to be calling that kind of the bridging contract between where our big change in the way we actually look at exactly what you're talking about. In other words, the way medicine is changing. In other words, the change from pay for procedure to pay for value. That's the nug work's going to be, and really we're going to see what we can get into 2017. But we're really going to be looking hard at what we're going to be calling 2022 or whatever the date we're going to be talking about. So it's really 5-year increments. But yeah, so you're spot on, and from a strategic perspective, we're thinking along the same lines. Yes.
Probably have time for one more question.
Yeah, one more question. And then, like I said, all of us will be here at the end, so you can ask any and all questions you want. So one more question. Yes, ma'am.
Nancy, I was retired in general, was part of the TRO organization and I left the community service, and I haven't heard any mention of the TRICARE regional offices. Do they fit into this?
Yes, ma'am. So, to be honest with you, and I'm gonna tell you a little secret, okay? Had we had a military health system conference, okay, we would have had an entire conference talking about, again, globally what we're doing across the board. So each one of these 30-minute lectures probably would have been in 1.5, 2.5 hours, okay? So what you're getting is the executive version, and what we're doing is we're using examples like again, in business support. He just touched the wave tops of what is going on in business support. I just talked about wave tops of again, organizational construct. What you're going to hear from again, Dave Bowen is just skimming the waves in 30 minutes. And so the answer is yes. Yes, okay, so we're looking at a lot. In fact, what we're doing, I'm going to share something we're doing right now, is we've got this concept, if you've heard, called the Ubertro. Ubertro, okay? So what happened is we had the 3 TROs, okay, and they're all doing great work, okay, but what you're talking about now is not one TRO, but what you're talking about is all 3 TROs working off the same set of metrics or the same set of X, Y, or within contractual, the current contractual obligations. But so we're going to drive the enterprise, in other words, from the Defense Health Agency, okay, from the Healthcare Operations Directorate, okay, and then the TRICARE Health Plan is inside that, okay. We're going to drive, this is what we want the enterprise to be driving to, and then have all 3 of the TROs. And then they're all kind of within reasons, but for example, TRO South, that was all pretty mature in looking at a lot of things. So we're taking kind of what the best of the 3 TROs are doing, okay? And then there's going to be a single, we're calling them the Uber TRO. So we're actually hiring an Uber TRO director that's going to seriously manage all 3 of the, we're still going to execute 3 TROs. but working off what I will call a common roadmap. Does that make sense? That's a step in the right direction. I would hope you would agree, but yes, ma'am. Yeah.
Well, I would like to see more consolidation, but
We're going to get there, but contractually, we can't do that right now, okay? But we can drive measurements the same, okay? But then in 2017, then in 2022, yes, ma'am. Yes, ma'am. Okay, so we got to have our next speaker, and again, like I said, again, the little secret was this is all we wanted was give you a little bit of taste of what's going on here up at the high level, so to kind of pique your interest. So, all right, so, great.